All right. Welcome, everyone, to this Department of Medicine from McMaster University Zoom meeting. We are currently live and recording right now. We know that other people will be joining in. There's a meeting with some of our Zoom links. Apparently, there's two floating around. But welcome so much to this. I am hosting this on behalf of Dr. Crowther, who's online as well, but he's asked me to speak and introduce everyone here. So if I could have our main speaker please introduce himself. We have a great speaker from our own department. As Dr. Zain Chagla is a very qualified and wonderful infectious disease doctor from McMaster here, who is currently in the midst of dealing with a lot of this COVID-19 stuff. So I definitely think that there's definitely a very high interest in hearing his perspective on everything that's going on right now. So thank you so much for taking your time to speak with you. I'm gonna probably turn my attention now to muting everyone who's joining and not muted when they start. And if you do know yourself as being someone who is coming in as a guest, please mute yourself as you enter if you hear me talking about this. But Zain, if you want to do it,
Yep.
take it away, please.
Perfect. Thank you for the introduction. So I'm Zain Chagla. I'm one of the infectious disease physicians at St. Joe's, and along with my colleague, Dr. McMaster, have been doing a lot of the medical director work for infection control at St. Joe's, as well as some social media around COVID. So I would encourage all of you, not shamefully trying to plug my Twitter account, but please join. I usually do post some updates here and there about articles or things that I find interesting. Okay, so today is going to be a scientific update, and you know, there's a lot of things going on around COVID-19, and this is evolving day by day. And I really wanted to make sure that what we cover today is scientifically grounded, really based on best evidence, and really an update from 2 weeks ago when Dr. Mertz, my colleague from HHS, gave a talk on the basics, and really just building on that in terms of what's come out in the last couple of weeks. And some controversies around the topic. I want to start this presentation. So many of you who know me personally know I'm a major Raptors fan. This was May 12th. This was the day that Kawhi Leonard hit that glorious shot. And this was right afterwards. I had the pleasure of being at that game. And as much as we talk about our processes, our systems, and everything going forward, I really want to bring it home to people that, you know, if you look at this entire stadium full of people, there were 20,000 in attendance that day. As of this morning, that's how many have passed away from this infection. And, you know, it seems like just the beginnings of a small number, but there are 20,000 people who by no fault of their own contracted this virus and unfortunately passed away from it. So I really, really want people to remember this in terms of the messaging going forward, and our role as providers in terms of hopefully combating the mortality we see here. On a happier note, this is my daughter. She's hopefully not going to pop in on this video, but you know, she's 8 months old, and the virus came out when she was 4 months old, and it's, you know, in the 4 months she's changed. This has changed day by day too as well. And so what I talk about today may not be relevant in 2 months and 4 months and in 6 months. It's the pace of progress around this, the amount of clinical description has just grown day by day, similar to how she's growing day by day. And I think just to bring it home, one quote by Osler, you know, it is astonishing with how little reading a doctor can practice medicine, but it is not astonishing how badly he or she may do it. And really this goes back to the principles about this being an evolving field, this being in a field where evidence is coming out left and right, and there is a lot of gray evidence coming out too as well, a lot of evidence from case reports, from anecdotes, from reports from the front lines in countries that have been affected significantly by this. As clinicians and as researchers and the McMaster community, we really need to adhere to the evidence behind these these decisions for diagnosis, for treatment, for the epidemiology, for the infection control, rather than relying on these gray literature pieces to inform our clinical practice. So in terms of conflicts of interest, I have none as they pertain to this presentation. There's unfortunately no therapeutics that have been approved for coronavirus, so I've not been sponsored by any of them. I am going to stay as much, I'm going to refer to as much of the peer-reviewed literature as possible and stay as well away from grayer literature as possible. One of the interesting things, and just as a side note, the pre-peer-reviewed online journals have taken off quite a bit with some of these publications, and I've had to source a few of them. As much as I can, I've tried to source peer-reviewed journals, but again, there is a number of reports from universities or from small groups which aren't validated, that I have no access to the primary data, and I'm really trying to stay away from those as part of this presentation, as I don't think that's been as rigorous as possible. I've tried to, as you know, Dr. Crowther had emailed out last week to answer as many questions as possible through the content of this presentation. I will try my best to leave some time for questioning, which will be done with the chat feature, and I think Teresa reading them out. But I apologize if I can't get to every question along the lines of this presentation. So I'm going to go through a few updates in epidemiology, a few updates in disease pathogenesis, some controversies that have come up regarding certain receptors and medications, a bit of an update on clinical presentation and some atypical features, a little bit on diagnostics, and particularly looking at our diagnostics at St. Joseph's and Hamilton Health Sciences and some of the validation. In terms of treatment, two major, I would say, papers. I wouldn't say one was not a clinical trial, that have come out, and just discussing the evidence around that, and time for just some thank yous and questions going forward. So this is the World Health Organization situation report from yesterday. I bringing the attention to the fact that the highest burden of disease is no longer in China. It is distributed through Western Europe, so Italy, France, Germany, Spain, Portugal, and Switzerland have seen probably the biggest burdens of disease, as well as the UK. The United States is not far behind. But the other thing I really want to emphasize is the countries that seem to be reporting the major amount of cases are the ones that have the competency testing. I don't think there's going to be a difference between what we see in areas of the world that have very minimal access to testing in terms of the prevalence rates and incidence rates. They're artificially reduced here. But I do think this is a global issue, and unfortunately the burden of the disease is going to hit low-income countries much higher than they are going to hit resource-intensive countries like ourselves. This is data from the United States as of yesterday. You see the epicenter of the outbreak is in New York City, 33,000 cases, which is again almost I think I just may have gone back on mute. Teresa, did I just go back on mute?
Yeah, I just fixed that. Yeah.
Okay, perfect. Although you see a distribution throughout most of the United States here, other hot pockets in Florida, Washington State, and California, which go with population density. But this is an evolving outbreak. There's been issues with testing in the United States, so this is probably much more of a tip of the iceberg than the actual prevalence of cases. And as we'll talk about a bit later, even some data around asymptomatic cases. There are some models, and modeling has become such a hot topic these days, suggesting the burden of disease in New York is significantly higher, in the millions. And so these are probably very, very big underestimates of the true burden of disease in the United States. As of yesterday, this is the Canadian map. So there was a big surge in cases in Quebec, which may have been more due to testing rather than anything else, and reporting of testing. In Ontario, we have 688 cases, but there are several thousand cases that are still waiting in provincial testing laboratories. And so probably not a reflection of our true numbers as of today, probably our true numbers as of about 4 or 5 days ago. BC and Alberta have also had a significant burden. There is the only place in Canada that has been spared is Nunavut, which has 0 cases, but Yukon and Northwest Territories, as well as even PEI and the Maritimes have all seen a single or multiple cases. And finally, this is just local data from Hamilton. I do want to emphasize a couple of things that are going on with the Canadian data, which are being reflected in the Hamilton data too as well. Number one is community spread is being seen. There was a report in the Globe and Mail a couple of days ago suggesting 45% of total cases across Canada were derived from the community. Ontario's data from the last check was more in the 10 to 15% range. In Hamilton, there have been 2 cases that are definitely community acquired, and a number of cases that are pending investigation in terms of travel acquired versus community acquired. The distribution is throughout all populations, and 4 cases hospitalized to date, and unfortunately we at St. Joe's dealt with a single death from the coronavirus, and not dissimilar numbers to what's happening in our region in Niagara, although the burden is slightly less there, and Halton too as well. There have been a number of people that have been going to the assessment centers, and one of our institutions in Stony Creek, Heritage Green, is under outbreak too as well for 2 residents that have tested positive. So one of the issues that's been coming up more recently is this concept of asymptomatic carriage. And so whether or not there is a significant burden of people infected that have very minimal, if not no symptoms, as well as what really does that impact in terms of the actual transmission. So we know a number of infections, there is asymptomatic carriage, or at least a pre-symptomatic phase. We know viral loads can certainly be approaching that of people that are symptomatic, but the role to play in persistence and person-to-person spread is very controversial. So one of the interesting parts of this outbreak is we've had a number of epidemiologic studies done on populations that have been going from very intense infected places to essentially areas where there's been 0 infection. And so the first big descriptions on asymptomatic carriage were this flight coming back from Japan, where they tested everyone aboard the flight. These were people that were evacuated from Wuhan as the initial outbreak went on. They swabbed them, and 4 people on board, about 13% of people on the flight, were actually asymptomatic. Now, they didn't know what the actual transmission of those patients were, but it was one of the first documentations of people just having absolutely no symptoms, but having relatively high viral loads. The Diamond Princess ship, I think that we all know about, which was a bit of a disaster, but an incredible epidemiologic experiment. There's a really interesting article describing kind of the cruise ship process in MMWR available through the CDC that just came out a couple of days ago. But this was probably the closest to a natural history experiment that we're going to get. The Diamond Princess had approximately 780 cases. They were swabbing people repeatedly. They were swabbing people on discharge too as well. And 46% of those people were asymptomatic. So 331 of about the 780 cases on the ship were asymptomatic as part of that. And so again, this was an older population that was generally on this cruise ship, so may not actually be reflective of the general population, but there is some degree of asymptomatic shedding, and whether or not it's 46%, or if you actually apply it to a natural distribution within age, whether or not it's higher, as we know that children and young adults tend to be more asymptomatic than older adults. There are some modeling studies ongoing. There was one suggestion from, again, a preprint journal coming out of China that was sponsored through Harvard, that actually 60% of the cases in the Wuhan region, the growth that they saw in the Wuhan region, could not be explained simply by the positive cases that were identified to date. and had suggested about 37,000 undetected cases in Wuhan. And again, multiple studies, kind of controlled studies or family cohorts, suggesting that the viral load in these asymptomatic cases approaches that of the viral loads in people with minimal symptoms, mild symptoms, not necessarily the people that are critically ill. Now, the question is whether or not these asymptomatic shedders are a source of infection in the community versus just, people that may infect close contacts where there's more close respiratory environments, more shedding into the environment, more fulminate-based transfer, that type of thing. So as this was being, again, people were going from very vulnerable areas to very isolated areas for the virus. There were transmission chains seen. So the first one that was described was in the New England Journal. There was a Shanghai traveler that was in contact with her parents from Wuhan that had showed up to Munich at a business conference and had infected a number of people at that conference. Now, it was interesting that New England Journal article said she was asymptomatic at the time, but the authors had not asked her whether or not she was having symptoms, and she had reported to others she was actually feeling quite jet lagged, had taken Tylenol, and so maybe she was actually mildly symptomatic rather than asymptomatic at that point. There was a similar case series in JAMA of a Wuhanese traveler that had come to Singapore and an entire family cohort that was infected. Again, at the time, Singapore did not have local transmission, so it was really that source case. And again, the Wuhanese traveler really did not have symptoms throughout. And so we can at least say in these close contact settings, there probably is some degree of asymptomatic transmission, which makes sense. These are families, these are colleagues at a business meeting. There's probably person-to-person contact. There may be shared fomites, shared drinks, that type of thing. Whether or not this actually applies to a large population is still very controversial. This is a modeling study that was done in Science. That was looking at the data in China, the growth rate in China, and trying to describe it based on the reproductive rate of symptomatic individuals, and as well as looking at mobility data within China and geographic density data within China. And their conclusions were 86% of all infections were undocumented, and they may actually account for 55% of all transmission events, where the numbers that were just made of symptomatic individuals didn't account for the growth in infections that were seen. There's obviously issues with this data. It's modeling, it's based on reported numbers. It's whatever you put into the model that comes out of the model. But as we get more and more data around this, and as more countries are doing big surveillance studies of asymptomatics, we may get a better sense of what the actual transmission rates are for these asymptomatic individuals. Moving on, just more from, again, an epidemiologic outpoint. These are Ontario data from UHN in terms of modeling, in terms of what's going on and what may happen in the near future. These are two scenarios that were built through UHN, and the modeling site is online. And so this one was in the context of social distancing. So the conservative scenario where the infection rate spreads very slowly through the population. The gray is ward beds, the yellow being ICU beds, and the blue being ventilators. And again, this is not incidence, but resource allocation. And you can see day one being mid-March, with the conservative social distancing method, day 35, day 40 is where we may start seeing the peak of cases. So kind of early to mid-May. There are studies being done at HHS, St. Joe's, and through the city of Hamilton, looking at regional data in that context to see whether or not our models seem to fit with this. But there certainly may be a strain, and this is again Ontario-wide, so accounting for some of the geographical variations in terms of patients' care. But we may start seeing the strain in about a month to a month and a half if social distancing keeps up. This is the Italy scenario. So this is the scenario of social distancing was instituted way too late, and things spread rapidly through the population, as we're seeing in Lombardy and Bergamo. And so if we said mid-March was day 0, by end of March, essentially, we're seeing a run out of ICU resources, and by the beginning of mid to late April, we're seeing the run out of essentially hospital beds. And so, bottom line, I think most of us in public health are really, really, really enforcing social distancing, and see the evidence for ongoing therapies for prevention and treatment are not effective to date. And so really, this is going to be our major intervention to avoid health system strain. Hopefully more modeling data will be coming out. And again, we're working with the City of Hamilton and HHS to come out with some modeling data that appropriately describes our own situations too as well. Moving on to disease pathogenesis. One of the newer, or at least older, discoveries that's being revisited is the attachment of the virus, and whether or not novel therapies, as well as other therapies that patients may be on, may actually affect this. So the ACE2 receptor is extremely important in SARS binding, but as well as SARS-CoV-2, which is the current novel coronavirus. It is the receptor for binding. ACE2 receptors are found actually throughout the body in certain compartments. ACE2 is a reversal agent for the angiotensinogen renin-aldosterone system. So remember, you get renin and ACE going from angiotensinogen 1 to angiotensinogen 2, whereas ACE2 actually goes the opposite direction. And so you, rather than getting the vasoconstriction that you get with ACE, you then get vasodilation with ACE2. And so this has created a lot of controversy at whether or not upregulation of these ACE2 receptors has a role to play in disease pathogenesis. And there was a lot of controversy, particularly around the initial data sets that had come out in terms of the epidemiologic studies of the first 1,100 patients from Wuhan, and further data around the first few patients that were developing ARDS, where rather than in H1N1, where they saw immunosuppression being the major risk factor for adverse outcomes, here it actually seemed to be much more associated with hypertension and vascular disease. And so this ACE hypothesis was brought up quite a bit more. We know, although ACE inhibitors don't directly upregulate ACE2 expression, they are upregulated in the context of ACE inhibition. And so whether or not there are more targets generated from this, and so there's a huge controversy of whether or not patients who are on ACE inhibitors should be taken off ACE inhibitors, whether patients who are admitted to hospital should be taken off ACE inhibitors to prevent spread of the infection. Interestingly, there is other work that actually suggests the opposite. So there's an acid wash model for SARS where they caused lung injury in SARS infection, where downregulation of ACE2, so a lower number of ACE2 receptors, was associated with worsening lung injury. And so maybe ARBs may be actually protective. The higher levels of ACEs may be protective. And so this is an area of controversy. I think this is being investigated thoroughly throughout newer cohorts. I do want to say the jury is still out on all of this. The American Heart Association, the Canadian Cardiovascular Society, the European EuCardio have all suggested there's no clinical data in patients that are on ACE inhibitors to continue their ACE inhibition while in hospital, to not reconsider the use of ACE inhibitors in people with hypertension currently, and really just to ignore the data until better evidence becomes available. And there are clinical trials now set up looking at losartan as a potential modulator of infection for early infection, and whether or not downregulation, whether or not reversing that downregulation may actually provide therapeutic effects. So this is something that'll hopefully come out of the pipeline in the next few weeks. NSAIDs are also one of the areas that became very controversial recently. There was some commentary, so a Lancet publication looking at patients with poor outcomes. The French health minister actually had a tweet saying they were seeing these with ibuprofen, patients that got high doses of ibuprofen prior to coming to the hospital. There was actually nothing published about this. The French government then put out a statement saying avoid NSAIDs, particularly ibuprofen, in patients who have SARS-CoV, and the UK government followed suit. It's interesting, the World Health Organization actually endorsed this recommendation, and then a day later completely turned face when there was really no evidence around this topic. The DOT mechanism is similar to prior, where NSAIDs may actually increase ACE2 receptor expression, and so whether or not that's the cause, so far there's no signal seen in any literature to date. The World Health Organization has said not to consider ibuprofen a restricted drug in people with coronavirus. Again, this data will probably be coming out down the line in some sort of case control study. But for now, NSAIDs are considered part of care if it's needed. Obviously, if they're not needed, it wouldn't be prescribed, particularly patients with other underlying issues like hypertension and renal injury. But this is an area where there was a lot of concern raised over social media without any real evidence to suggest an effect. Another article that came out recently was this correspondence from the New England Journal of Medicine talking about aerosol and surface stability of SARS-2 as compared with SARS-1. To my regard, I think this was very poorly written in terms of the mechanistic model they were going for as compared to the typical human model of droplet contact transmission. And so they used this fancy aerosolizer, which is this big drum that will aerosolize particles to a very small amount. This is the equivalent of doing an aerosol generating procedure on a patient. However, the article didn't explicitly note this, and in fact, if you read through it, there's some wording nearby that isn't suggestive, but may confuse the reader to suggest this is a typical cough model, but it is not. This is an aerosol generating procedure model of the half-life of coronavirus particles on different surfaces, including moisture within the environment. So in this study, they essentially aerosolized the compound. They saw it fall they took samples of air and looked at 3 other materials, copper, stainless steel, and plastics, to see what the half-life of was for decay of the coronavirus. Remember, viruses are, they do exist in the environment. They're enveloped. They do have some environmental sensitivity. They're prone to dehydration and breakdown by that point. So their stability in the environment is certainly there for a set amount of time, but they're not going to stay in the environment forever. And so in this study, air was about an hour so that it stayed as the half-life. Copper was about the same. Stainless steel was about 5.6 hours, and plastics were about 7 hours. And so if you look at the 5 half-lives on plastics, which I'm copying a pharmacologic model over onto this model, we're talking in the 1 to 2 day range. Things are remaining on plastics, but again, they were doing this via PCR testing. It's not clear whether or not that actually translates over to infectivity rather than just finding molecular fingerprints and molecular suggestions. There was some look at the Diamond Princess ship where this may have been as long as 9 days, but again, molecular evidence rather than clinical evidence of infection. So no surrogate to say infectivity rather than just some residual virus that may or may not be viable. I get asked a lot of questions around what is the contamination within a room and clothing. This is a single patient experience in Singapore that was published in JAMA about 2 weeks ago. So this followed a patient around in an airborne room and kind of swabbed everything within that room. The good news is that all of these samples before cleaning after cleaning went to negative. But in a typical single private room in negative pressure, the patient contaminated their bed rails, their chair, their light switches, the sink, the floor, the windows, the toilet bowl, and not a lot of the PPE. So the staff PPE was actually isolated afterwards. The upper part, lower part, front surface of the face visor, and the N95 mask based on swabbing were all negative. The surface of the front of shoes was positive and probably a reflection of colonization on the floor. but at least a little bit reassuring that general clothing may or may not be a major issue, especially in the context of removable PPE. How much of this would actually get on clothing underneath if it was taken off in an appropriate manner is still very controversial. But in a typical exposure situation, again, for a hospitalized patient, we may not actually be seeing a lot of it ending up on clinicians' clothing rather than the patient's environment. But also to be in context that the patient's environment can be very heavily contaminated by this, and so that hand hygiene after encounter with the patient's environment is exceptionally important, as well as the cleaning that we're instituting amongst all of our institutions. I have to include something funny in this presentation. So your COVID-19 test came back positive, and the gentleman underneath says, that can't be correct. I have more than 300 rolls of toilet paper. Moving on, I want to talk briefly about the clinical presentation and some updates. So the initial 1,099 cohort that was described in the New England Journal really described fever, cough, and worsening shortness of breath, which became a mantra within our case description. There are other symptoms that are starting to be described as part of this. So myalgia is the European Society, the UK Society for ENT has also described anosmia as an initial symptom, which is a bit difficult given it's allergy season here, and a lot of people have allergy-induced anosmia too as well. Conjunctivitis has been described in a number of cases. But I do want to bring up one article that's important. This is actually a study from the American Journal of Gastroenterology that was actually released, I think, about a week and a half ago, looking at gastrointestinal symptoms as the preceding symptoms for infection. And so in that initial New England series of 1,100 patients, diarrhea was actually a very uncommon symptom, about 3.5%. In this description of a further cohort, multi-center in Hubei, gastrointestinal symptoms were actually found quite early in the process. And so anorexia and diarrhea tended to be early symptoms. Interestingly, when they looked at patients without gastrointestinal symptoms, the people with gastrointestinal symptoms tended to have a longer disease course. They tended to have more end organ disease. And there was actually about 6 patients in this cohort that presented with only diarrhea-only syndromes. And it's still very unclear whether or not those people were having diarrhea from another reason and were asymptomatic shedders, or the diarrhea was actually induced by the coronavirus. There are some small studies suggesting that it can be isolated from stool in a small percentage of patients, whether or not that's an actual infectious dose in stool or it's just molecular evidence of this. But bottom line is, I think we do need to consider gastrointestinal symptoms as part of the complex. A lot of these patients did go on to develop respiratory symptoms, so it became much more clear. And certainly there's a lot of things that give people intermittent anorexia, diarrhea, nausea, and vomiting that aren't coronavirus. So the positive predictive value of these symptoms as compared to everything else that goes on in the community is not as high as we would expect. But just to keep this in the back of the mind that the person with these symptoms might be better off isolating at home, watching for respiratory symptoms, and then sending them for testing if they do develop multiple symptoms or fevers or anything along those lines. This is also another study that was taking a look at that German cohort. So as I had talked earlier about that cohort of people that were exposed in Munich, that were exposed to that single traveler from Shanghai, the Germans actually took a good look at these people's viral kinetics and their shedding during the duration of their illness. This was very early in the transmission cycle that we're seeing now. So these patients were all actually hospitalized, even though a lot of them could have been isolated at home, but they were studied during that hospitalization too as well. And so the bottom line from this cohort of patients from Germany that were exposed, the PCR was found to be quite sensitive. And so they used culture-based techniques to actually determine whether or not it was a viable virus or not a viable virus. The viral load was actually quite high from about day 1 post-symptom onset to about day 4, where the peak was. They could culture the virus out of throat, NPS, and lung tissue. And despite actually in this study, they tried to look for virus in stool, like viable virus in stool. They were able to find molecular evidence on PCR of virus in stool, but were never able to actually isolate viable culture. And so the infectivity of stool in this cohort seemed to be much less higher up. For those who recovered, there was relatively minimal viable virus on day 10 of illness. And this was associated with a serologic response of IgM and IgG. We'll talk about serologic tests a little bit later. But important to note, as we're talking about our community-based interventions, particularly in settings where we're not able to access swabs for everyone with symptoms, that 14-day rule is probably reasonable for the bulk of patients, as their amount of viable virus is significantly decreased by day 10. This is also going to be an issue for the patients that are recovering at home who have been virologically confirmed to be positive. As we're running lower and lower on resources to test and shifting that towards people who need it more, we may make some arbitrary definition of 14 days post onset of symptoms as the isolation period for these people, rather than using molecular tests to descreen them, as you may get molecular positivity over time, but that may not actually reflect infectivity based on culture. And so public health is looking at this in terms of coming up with a streamlined definition in terms of deflagging, particularly now that we're seeing 600 patients in Ontario, and following those all to the ends of the disease might be a bit more difficult. Talking through diagnostic testing, I want to mention the test that's being done at Hamilton Health Sciences St. Joe's. So this is, so currently outpatients are being sent to assessment centers through public health. We'll talk about the case definition on the next slide. But patients within our institutions are using an in-house assay. We are using a different target, the UTR target, which in our validation studies has equal sensitivity to the envelope target that PHL uses. PHL uses the envelope target plus RDRP. We've tested 700 clinical specimens in parallel with the clinical lab with public health to go through this validation process. The specificity has been 100%. But a swab is only as good as the person swabbing, and so there are some caveats here. Number one is people may not shed all the virus completely. They may have very low viral loads, and their kinetics may change on a day-to-day basis, as when we look at the Plaquenil trial. And the specimen collection may not be perfect. In talking with the lab folks, they did look at epithelial DNA on the first 700 swabs that were done in a research context, and there was epithelial DNA noted on all of them, good amount. So at least the technique has been reasonable for the swabs that we've sent to date. This is our local case definition, so Ontario's case definition. So travel to an impacted area, contact with COVID, or close contact with someone with acute respiratory illness who's been to an impacted area and whom COVID testing is recommended or unavailable. Now, this is a definition that will likely change over the next few days to weeks as we see much more community-based transmission. Certainly in our hospital setting, anyone that you think is at risk who's presenting with upper respiratory symptoms, regardless of travel history, consider testing on. And I think that will be the practice of the communities as we get to settings where resources for swabs may be limited, and certainly we're seeing this in British Columbia. This may be limited more to people with mild disease, stay home, healthcare workers, those from vulnerable populations like shelters, jails, and Indigenous reserves. People who are hospitalized or from long-term care may be more qualified for testing even in the context of mild disease, whereas people who have very mild disease without any of those subgroups would be just encouraged to stay home for the duration of their illness. Again, I talked about this negativity result. It's a difficult issue as the Chinese assay suggested the swab sensitivity is 70%. Our assay is probably a bit more sensitive than that Chinese assay. But as you'll see when I describe some of the French data, there is intermittent shedding even in the patients that test positive. They can test negative the next day and positive the day after that. So the bottom line is this is like any other disease process where you still have a pretest probability. So people presenting with compatible symptoms, we are seeing community spread now. So travel is only a positive risk factor. It should not be a negative risk factor. And in patients that are intubated from the experience from SARS, ETA or lower tract sputums may actually be a better sample in that sense. The surviving sepsis guidelines that were published by Walid Al-Hazani and his group had suggested weak evidence, but in patients where the clinical context is right, to consider sputum and ETAs testing. And we are debating on what to do next for patients that are very high risk that show up, or high pretest probability that show up with a negative test. We may have a strategy of re-swabbing them, but this isn't standard of care yet. But keep an eye out for what we decide on these for patients that can't produce sputum or ETA specimens. Serologic kits are coming out. There's point of care testing moving to the USA and Canada. The roles of this are going to be interesting, whether or not you can do seroprevalence studies, whether or not it's a method to actually get people out of isolation earlier by just doing a point of care serologic testing. They have a good antibody response, and that might compare to viral shedding. And for healthcare workers, it might be a good test to see, okay, who should be on the front lines. Those asymptomatics that have developed a good IgM, IgG response might actually be better to go on the front lines rather than people that haven't. I'll quickly skip, as I want to keep some time for questions, to 2 clinical trials that have come out to date, which are probably the most important evidence that's come out so far about the coronavirus. Lopinavir/ritonavir is an old combination of protease inhibitors used in HIV therapy. They're actually still used quite a bit in low resource settings, so there is a lot of interest in this as there is supply in some settings for this. The protease is involved, as in that diagram earlier, when we looked at ACE2 inhibition and a secondary receptor 2 as well. The protease is actually involved in that second receptor and breaking it down. And so potentially protease inhibitors may play a role in that second co-receptor process. Now, this is not a clean drug. There's lots of drug-drug interactions. It is very nausea and vomiting and diarrhea provoking. And so really a good look at this evidence to see whether or not it's worth it to put patients through this that already have physiologic disturbances. And there's certainly in vitro and in vivo data in SARS. It was used as late as 2004 for SARS, and the Middle Eastern respiratory syndrome, where it's been used as off-label treatment too as well, suggesting some benefit. So this is an RCT that was done. Just before we go through it, I want to recognize how incredible this RCT came out. So this was enrolling January 18th to February 3rd and was published last week in the New England Journal of Medicine. And so a clinical trial from beginning to end in terms of enrollment, data analysis, manuscript preparation, and publication to be done in a 2-month window from enrollment is absolutely unheard of. And so I really do want to give respect to these authors that push the scientific knowledge forward. This was an open labeled RCT, 1-to-1 ritonavir, 100 milligrams POBID. It was given either as pills or oral suspension versus standard of care in a single center in Wuhan. This included people greater than 18 who were PCR positive, who had pneumonia on imaging. So this is very different than some of the mild cases we would see. SATs of less than 94% on room air, or PaO2 or FiO2 ratio of less than 300. It excluded physician preference, people had allergy, people had cirrhosis or on metronidazole. The reason being is the oral formulation of lopinavir ritonavir actually has a significant amount of ethanol that's used for its reconstitution. So it can't be given to people who can't tolerate it. People who had major drug interaction, who are HIV positive, as it would screw up the regimen, and people who are non-pregnant breastfeeding. They stratified patients by O2 method, so no O2, O2 by NP or face mask, high flow O2, negative pressure ventilation, or patients that were ventilated or who were on ECMO. The primary endpoint was time to clinical improvement. They used a 7-point scale where 1 is being home and back to baseline, 7 is death, 6 is ventilated on ECMO, and so there's a progression in between. They looked at secondary outcomes in terms of day 7, 14 clinical status, and 28-day mortality. Generally, the populations were relatively well assigned. 199 went through randomization. There was only a couple of patients that dropped out either through death or a couple that crossed over into the safety populations, but generally well recruited and not a lot of drop off. The one thing I want to point out in terms of the table 2, but the table 1 is the time this was actually given to patients. So this was given day 13, which is a little bit, as we talk about critiques of this article, may not be the appropriate time interval to be prescribing antivirals in the sense that the damage may be done. But otherwise, relatively well balanced between the two arms. This is the survival Kaplan-Meier curve, but essentially no difference between lopinavir, ritonavir, and control in terms of that cumulative 2-point improvement. This is viral loads of those patients too as well. And initially, the lopinavir, ritonavir patients actually had a higher viral load, but by the end of the trial, they essentially had petered out to about the same. And the bottom line is Kaletra, lopinavir, ritonavir was no more benefit than standard care. There was a slight signal towards potentially 1 day less of discharge and slightly more clinical improvement day 14. Although on the intention to treat analysis, that was not seen. There's not really a virologic benefit for this process, but I think us in the community have a really big issue of when this was actually administered. So day 13, when patients are relatively ill in this study, the damage may be done. As we know, this may be more of an immune modulated disease after a certain point than a infectious disease. And so shutting down that process, the damage may have actually been done by that point, and you may not actually see a clinical response. And so I think Kaletra does need to be studied more, and there are certainly other groups, including the World Health Organization and CATCO, looking at this, but in a trial setup that needs to be given early rather than late. The last trial I'll talk about is this hydroxychloroquine and azithromycin trial for COVID-19. This is a trial that was published in a very relatively, I would say, unknown journal, so the International Journal of Antibiotic Therapy, by a French group in Marseille. And so this was a single center trial. It's not really a controlled trial, as we'll see. So the single center had the intervention of giving hydroxychloroquine, multi-center for the control. The Marseille patients got hydroxychloroquine, and Marseille and region patients were used as the control. These were PCR patients, over 12 with no contraindications and not pregnant or breastfeeding, although hydroxychloroquine is relatively safe in pregnancy still. They were followed virologically, and we use cycle threshold for people who don't have a molecular knowledge. Cycle threshold is the cycle of PCR where we start seeing fluorescence more than the baseline. So really when we start seeing a positive signal, the longer the cycle threshold, the lower the viral load is technically. So cycle thresholds of 40 are considered negative, in this trial 35, which is a bit of an issue. And lower cycle thresholds, so 1, 2, 10 are considered very high viral loads. 6 patients also had azithromycin thrown on. It's not really clear why. The article says it's for bacterial superinfection or prevention of bacterial superinfection, but the patients that had azithromycin thrown on were not randomized by any means. It was physician's preference alone. When we look at the actual recruitment and results, 26 patients were recruited in the hydroxychloroquine arm as opposed to 16 controls. 6 patients of those hydroxychloroquine patients actually dropped out. And it's important, we'll talk about what the caveats of those people are. There were about 17% of patients that were asymptomatic, 61% that had an upper respiratory syndrome, and 13% that had lower respiratory symptoms based on CT findings of pneumonitis. This was the finding that made headlines. So hydroxychloroquine as compared to control, the percentage of patients with positive PCR samples was less. So this was just swabbing people, saying if they were positive or negative on a certain day, and the percentage of patients who were positive were higher in the group that got nothing versus the percentage of patients that had hydroxychloroquine. This is not quantitative in terms of what cycle threshold or anything like that. So that's one big caveat to this. When they added azithromycin, the amount of patients that had negative results were even higher in the azithromycin plus hydroxychloroquine group. And so this got a lot of press, but there are huge issues with this data. Number one, those 6 missing patients, 3 of them actually went to the ICU and they were PCR positive. So they would actually be counted as people probably, as we know in patients that are critically ill, they tend to shed a lot for a long time. So they would have actually been counted as positive cases as compared to the other 20. 1 died that was PCR negative. 1 left the hospital PCR positive on day 2. And 1 decided to stop the medication on day 2, but it was also PCR positive. These were not included in the analysis, but potentially 5 other patients that were PCR positive that were not counted, and essentially the 20 were based without this. There's no real clinical data in terms of how these patients did. And so virologic shedding is fine. We know from experience people can shed virus for some time. Does that really mean anything in the context of, is the patient actually getting better more than anything else? I'll go to the primary data too as well, just briefly. This is a difficult chart, but the first 16 patients here are the controls, and the ones 17 or down are the intervention group, and the last 6 are the ones that got azithromycin too as well. You can see some patients here in the control group actually didn't get swabs on consecutive days. In the analysis, they counted them as positive if their swab the day before was positive. But if you look at the table down where the patients that got the intervention, there are some patients here that had positives and negatives and positives the next day. So it's not entirely clear whether or not that analysis on the top of the controls is actually entirely accurate. The other thing here, and especially in that azithromycin arm, you can actually see the cycle thresholds for those patients tended to be much higher. So you see 29s and 30s at baseline for those patients. So those patients had very low viral loads to begin with, and then they cleared very quickly. Whereas if you see in the hydroxychloroquine group, they tended to have lower cycle thresholds, so higher viral loads up front. And we have no quantitation of viral loads in some of the control groups. So the bottom line is this is very gray literature. There is not a lot that can be taken from this to really say this was a positive trial. If anything, if it was reanalyzed, if we had those extra 5 patients, if you did proper swabs on some of those controls, the analysis may be completely different. And so I don't think this is a positive trial at all, and shouldn't be considered a positive trial. And so bottom line, again, this is not a positive trial. This methodology was completely messed up. But the drug does have in vitro activity, and I think there is an importance to actually studying this in a real rigorous clinical trial context. And I know the folks from PHRI are looking aggressively, and I really do hope that trial comes to fruition, that it can be given to patients, but watched for these clinical responses rather than this surrogate study of viral loads, which may not mean anything. Unfortunately, one person got a hold of this trial that shouldn't have, and put it on Twitter to say hydroxychloroquine and azithromycin have a real chance to be one of the biggest game changers in the history of medicine. I don't know if Donald Trump can do evidence-based medicine reviews, but he certainly put it out as if he could. And the implications of this are incredible. So there are global shortages on hydroxychloroquine now that were directly triggered by this tweet over this article. There are patients in the United States that were taking hydroxychloroquine or chloroquine that was used as aquarium cleaners as doses to prevent them from getting COVID, and have actually died of toxicity. And we just read this morning, there's a Kaiser Permanente has actually reached out to its patients that are on hydroxychloroquine for chronic rheumatologic diseases, stating they cannot stay on it because there is a nationwide shortage, and actually asking patients to be switched off hydroxychloroquine, which is a relatively non-toxic, stable option for immunomodulation in patients with rheumatoid arthritis and other autoimmune disorders, to be switched on to another drug. So this is irresponsible work, and it has had global implications. I don't think there's any evidence for hydroxychloroquine to date. But I think it does need to be studied in a rigorous setting before any of this gray data actually gets released around it. There are a few other compounds that are undergoing clinical trials that there is a bit of gray literature around too as well. Remdesivir, which was available by Gilead and is now being studied through clinical trials. Ribavirin and interferon. Favipiravir, which is a Japanese influenza drug, which is showing some benefit in some very observational trials. The CATCO group and the World Health Organization are trying to organize a trial called Solidarity, which involves remdesivir, Kaletra, and hydroxychloroquine or chloroquine, losartan, as we talked about, and then IL-6 inhibition in terms of turning off the pathway. And there is a big clinical trial starting globally with tocilizumab, and a second drug, Actemra, in the United States, which is also starting clinical trials, which again, in anecdotal settings seems to have provided benefit, but the single anecdote should not inform clinical practice going forward. So final thoughts, this is a relatively young infection and more data is emerging by the day. I think we need to treat patients aggressively, but use medication through clinical trials. We need to make rational decisions around infection control and spread. And unfortunately, the last thing I want to emphasize is the low and middle income countries are going to be lost in all of this. And for those of us who do have global health connections, to really go back and tap them to say if they need resource support or anything you could do remotely, it's going to be an issue for settings that we don't know the prevalence of the disease, but definitely is affecting them. I want to give thanks to a few people at the end of this. Number one, and the people I don't think that get enough recognition are the IPAC teams across the city, both at St. Joe's and HHS, that have been essentially working around the clock on this. Some of them taking 24/7 call to help with programmatic issues and patients. Those volunteering their time on multiple committees, both locally and provincially, the frontline workers who are seeing these patients and putting themselves at risk. The microbiology laboratory and Dr. Smea and his group, who have put together an incredible test in a short amount of time, have taken testing to another level, and have really been able to do quick turnarounds and help with our diagnostics, and everyone else that's keeping us safe, including the grocery store workers and taxi drivers and all those essential services that keep open. I realize we don't have a lot of time for questions. Maybe we can extend things for about 10 minutes and I can go through the top few. I'll leave it to Teresa, maybe to pipe in. Teresa?
Hey,
That's Mark.
no,
You're there,
can you just end your screen share and then we can go ahead through the questions?
Yeah. Stop the share.
Yeah,
okay.
Perfect. Okay. So the first question here is, how can we ensure that we have access to testing extremely high-risk populations like prisons?
So I think that's appropriate. And so public health units are looking at this as part of their screening strategy if we are down on PPE, and really trying to keep balance the populations that are high risk. So jails are considered one of those high risk populations. Those of us who are working in jail systems to really ensure that patients with respiratory symptoms have access to assessment centers, and to have a high suspicion outside of anything else. So I think those of us working in jails have a high suspicion. Send testing for people who you think have respiratory issues. It is obviously a big issue in terms of isolation, but first point is really just sending that testing. We've sent a few tests for people from jails in Hamilton, and so those of us who are providing care to continue to do that.
Okay. Another question is, Hypertension Canada also has harmony with other societies on peace and ARBs. So that was, I guess, just a comment.
Yes, CCS and Hypertension Canada.
Yeah. In terms of another question is, in the absence of respiratory symptoms and only GI symptoms, can stool be sent for COVID testing?
So I think I go back to that study where they tried to look at whether or not they could actually isolate it as an infective form in stool, and there is they weren't. So number one, I think stool is probably not as infectious as we think. There is molecular evidence. We're starting to talk locally at whether or not we can send stool in the right context, and but I do think you probably would be able to send NPS even recurrently in those patients rather than going to stool. Dr. Smea, though we've had early discussions though about developing a stool assay should we ever need it, which requires a bit more reagents and reprocessing before it goes to PCR. So it might be something possible, and certainly other groups have done it, but it requires a little bit more processing beforehand.
Okay. And if those with diarrhea don't have respiratory symptoms, do you have a sense of the sensitivity of the NPS for those?
So NPS, again, we're picking up a lot of asymptomatic patients with NPS. So it's still a reasonable test. That's still the entryway and the replication point of the virus. It's where the ACE receptors are. So it still should be the frontline test for those people. As we get more serologic tests, that might also be an interesting place to actually apply it to as well for that population.
Mm-hmm. There's a question about the survival of COVID on fresh produce, tomatoes, celery, lettuce, berries, etc.
Yeah, I mean, I think you'd apply the same data as we did in the plastic, stainless steel, and copper studies. So on those surfaces, there was some half-life. I don't think we're going to do a study, looking at tomatoes particularly. I would say in the hours at the most, 1 to 2 days. But again, whether or not the virus is still present versus the virus is still infectious is completely different. And so these viruses need moisture, need relatively stable temperatures to remain enveloped and have their ability to infect. And so although we might find molecular evidence, it may just be shedding or dying virus. So 1 or 2 days, use hand hygiene when handling your produce as you would all the time. But yeah, I wouldn't say anything different than that.
Okay. In terms of, it looks like Dr. Haynes and Dr. Yorio's group will launch a COVID-19 critically appraised evidence website April 1st to help
Awesome.
Some of this stuff. So,
which I think is hugely important here, right? There's a lot of great literature coming out, as I keep emphasizing here, and a lot of it's being passed around. So having a good central repository of evidence-based and critiqued evidence is as important as the evidence coming out.
Yeah, agreed. There's a lot of people putting stuff on bioRxiv or medRxiv, which is a pre-publication repository. And a lot of the journals are asking people to actually put it there first, and then they'll publish it still after. So yes, I think that there's a lot of misinformation that can happen if you're looking at stuff that's not actually even published yet, but rather pre-published, right? So definitely think having something like that will be important. Are the in-house assays here in Hamilton included in the NPS testing considered a limited resource at this point?
Not yet. And so the bottom line is people who need to be tested should be tested. Make sure you're testing people with a high pretest probability though, right? I wouldn't be sending testing on someone that presents with a broken ankle because I feel nervous about dealing with that patient. That's when we might run into resource issues and we'd have to scale that potential up. The bottleneck right now is not necessarily the testing kits and the reagents, it's really just the throughput. So I think we have a capacity for about 500 tests a day, which Dr. Smea is working to push up to 1,000 and higher. But you want to make sure those 500 tests are done on people that are symptomatic, on healthcare workers that are symptomatic, the people that really do need that testing first, rather than using them to just make yourself feel better about certain scenarios. Okay.
So the bottom line there is if your pretest probability is really, really low, probably don't test.
Exactly.
For people who your pretest probability is pretty high, you said test, and then if it's negative, if they're super sick, you may still want to retest at some point.
Retest or use ETA or lower track sputum.
Okay. This is I guess there's a high incidence of really sick people in some of the ICUs in the area. It seems that there might be people with severe ARDS that have been reported, and obviously definitely on the news and on Twitter and things like that as well. If someone was super sick in ICU, what would your advice be for patients with severe ARDS? Will we still try Kaletra? Is it too late? With hydroxychloroquine?
I think, yeah, I mean, giving unapproved drugs with unapproved indications where we have no clue, and it is disease, viral infections are double-edged swords, right? Like, we know certain vaccine trials have caused more pathogenicity for the viruses rather than less. And the ACE inhibitor concept is the classic for this, where an ACE inhibitor could be harmful or helpful for the virus. So the bottom line is, I think we do need to do this through clinical trial settings. We are looking, and I think the PHRI group As the GIM group, we're also looking at an approach for this so that we're prescribing drugs in a rational but evidence-based system where people have access through research trials. And the CATCO group, who's trying to work with the World Health Organization to get the Solidarity trial in Canada. All of those may be available to our patients relatively soon. And I'd encourage then to just refer patients to a randomized clinical trial rather than just treating them willy-nilly with the drug to say that we think this is going to work.
All right, the next question is, what's the average length of time for a person to develop the virologic load to become positive for a test? Like when is test?
Yeah, I think I had a slide on this where day 1 to 4 is where we saw in that cohort that they would develop day 1 to 4 post symptoms they would have, and their peak was kind of day 4 for the viral load. It started going down after that. But again, critically ill patients can be fairly high viral loads for some time and shed for some time. So it's very variable, patient dependent.
Okay, thank you. The next question is, given the data you presented, I don't think we'll be using empiric Kaletra or chloroquine outside of the context of a trial. Can you comment on the use of other antibiotics for, let's say, what looks like pneumonia, because there might be still regular community-acquired pneumonia?
Yeah, and so I think where there is a clinical doubt where it could be pneumonia, so someone presents with a lot of sputum, they had symptoms that could be suggestive of pneumonia, they've had recurrent pneumonia in the past, they've aspirated. There's a role to still give antibiotics. Not every respiratory infection is going to be COVID. Once it becomes very apparent that it's COVID and predominantly COVID, then I think there is an argument to stop antibiotics at this point. There was a bit of a push as well to give azithromycin to all of these patients. The 6-patient experience is the best data for that, but again, based on Donald Trump's tweets, azithromycin is on back order everywhere too as well. So we won't actually, because of this, have access to azithromycin for our patients that may or may not need it for other reasons. And so use drugs, if there is some question, if there is CAP within the differential diagnosis, once we're relatively reassured that it's COVID, I would actually discontinue these medications. As we're seeing more and more patients come to the hospital, if you imagine we're going to see 50 to 100 to even more patients being admitted a day that are on antibiotics that are being cohorted in hospitals, and they're getting antibiotics, that the last thing we need in an outbreak like this is a C. difficile outbreak too as well. And so be judicious about your use of antibiotics once things are very clear about what the diagnosis is.
All right. So the next question is, okay, just to summarize exactly what should happen right now, because it's probably just only for today, Thursday, March 26, 2020, protocols are changing from time to time. Mm-hmm. But when COVID testing in ED and the patient is then released to the ward, and I assume that the question meant that if this person is positive, when should we be wearing masks?
So everyone that is being tested for COVID where there's a clinical suspicion should be in droplet and contact precautions, period. Okay. And so the bottom line is, if you're thinking about it, they should be isolated as if they have it. Okay. And again, sorry.
I guess say the test was negative, because you said that it might not be
perfect. Yeah. So again, that's probably that concept of pretest probability, right? So if you have a low pretest probability, you find another etiology, it sounds much more like heart failure, then perhaps that person is someone that could be deflagged, although they should be watched to see that their symptoms don't change. As we're seeing community spread in hospital, and we know the incubation period can be as long as 2 to 10 days, they could very well then down the line develop respiratory symptoms and have to be isolated for that in that sense. But in the context of someone with a moderate to a high pretest probability, it's not as simple as deflagging them immediately. And I think you have to still look at the patient completely and consider either retesting, getting sputum, or getting a second opinion on whether or not we could deflag them.
Another point was by Dr. Kolb, who says tocilizumab is tocilizumab.
The IL-6 inhibitor.
Yeah, IL-6 inhibitor, MacEmerg. Yeah, is easier to say always, the trade name, right? Is relatively widely used in Italy, and I think that they're working in the front lines using it Roche seems to be doing an RCT right now as well. So that's the stage.
So I think again, we're looking at hopefully bringing that on board. I know I filled out some initial paperwork around this recently. So if we do get access to that, again, I would give it in the clinical trial context. I wouldn't necessarily be giving it outside of that, because as we know about things like activated protein C with sepsis, simply examining or simply interrupting a cascade may not actually give us the positive effects that we want, and there may be actually worsening downstream effects. So it really has to be in the clinical trial context.
Okay. The next thing would be, why does the case definition still refer to travel when we have active community spread, most likely?
Yeah, it's a good question. I think regions are coming up with their case definition on their own rather than relying on provincial and federal definitions. So the city of Toronto said test everyone that has compatible symptoms. I think as again, we move to more of a stewardship intervention in terms of our testing, we're not going to, most groups are going to just be throwing travel out the window other than being a positive predictive factor, and just focusing testing on the people that need testing for medical reasons, for healthcare workers, and for very isolated or people who are at high risk in terms of community spread, and then leaving the mild travelers, non-travelers alone just to isolate at home. So I don't know why it hasn't changed. It's more bureaucratic than it is evidence-based, but I think everything's changing by the day. I wouldn't be surprised by the end of the week, early next week, that the definition changes to this non-travel based approach.
Yeah, for sure. If you're working during a daytime hours, you may need to pay attention to the news, because middle of your day you may have something.
Yeah, something happens. Yeah, exactly.
The policy may change. I think what you're describing is kind of something more similar to the way that we judiciously do NPSs in the influenza time, where people who are being admitted, who are going to be going back to close quarters, maybe in vulnerable populations like in the prison population or in shelter populations, would be imperative to test and think about, right? So I think that resonates with a lot of us, but currently it's not the situation yet. Now, there's a rehab professional, Brenda, on the line there, that has been asking, are we tracking recovery trajectory for people who are on the other side of this? Is there any sense of what help or hinders, kind of like as people recover, especially for the very severe cases? People in ICU are not doing great, so I don't know how much rehab there is at that level. But maybe people are admitted, but not ICU territory.
I mean, I can say, again, this is anecdotally, the reports, even in people who are young and healthy, who are getting mild disease with significant symptoms, not requiring hospitalization, they're really, really, really put out by this. So they're not recovering like it would be just a typical cold and flu. And so you're right, rehab services are part of the plans in terms of scaling up. We're going to be dealing with a lot of patients that have been critically ill. We're going to be dealing with a lot of patients that may be on a ventilator for a week or two. And so they're not going to just walk out of hospital once they recover. A lot of them, especially as this is a disease of older people, are going to need rehab services going forward. And so, as part of being a rehab professional, this is probably something you'll be bringing up amongst your committees in terms of planning and building up that capacity, because that's going to be the second wave of people that need care.
In terms of the COVID, as a clinical diagnosis, if you had negative swab but super high clinical suspicion and suspicious CT findings and low lymphocyte count, etc., like everything says COVID. That's probably COVID with a negative swab and a false negative. Right?
And as we saw, like in that French data, right, there were people that were negative and positive at a day apart, and then positive again afterwards, right? So it may just be the day you screen them, they're shedding, that type of thing. So they have a high pretest probability. Don't take them out of precautions. If they're intubated, send ETA specimens. Or if they're making sputum, consider sending sputum specimens. I wouldn't induce a sputum on any of them because that's aerosol generating. But if you're really like, I think this is COVID, I'm pretty sure this is COVID, this has classic COVID features, continue to treat them as COVID until proven otherwise.
Okay. Now, I guess a follow-up to that would be, in the setting of someone who has respiratory symptoms, how often are we supposed to be CTing them? Is it just more that we're like maybe looking for other things like DVT or something like that?
So
PPE or something like that people are getting scanned? Like, what's the context? I know American centers are scanning fairly liberally.
I think we're actually doing a bit more the opposite. So just to reduce patient movement, if there is, to get patients not, again, moving around the hospitals, if it's just to confirm COVID, then doing a CT scan is probably not the optimal test if you have a positive NPS or very, very high pretest probability and they're in respiratory failure, because we're not going to do anything different. If there is an alternate diagnosis on the list, so if you think they have a pulmonary embolism or they have an empyema or some other process that requires CT scanning, then that may be appropriate for that patient. But simply for the COVID, doing a portable chest X-ray, which doesn't have the high sensitivity, and your NPS testing and your clinical suspicion is reasonable for the sake of not having to move patients in and out of diagnostic radiology in that standpoint. So I, again, would advise that you're doing CTs only for things that are going to change clinical management, like pulmonary emboli or empyemas or pneumothoraces and that type of thing.
All right. I'm just cherry picking questions now because we're really a little bit running over time. If that's okay. I guess there's a shout out to a new Chinese RCT that showed hydroxychloroquine was negative yesterday. So
yeah, it was also a very great journal, so I didn't want to put it in that presentation. I think it was a letter from the Beijing School of Health Sciences.
I guess there's a question about like what's the difference between the public health, what is the bottleneck for the public health testing versus the in-hospital testing?
Yeah, I mean, that's a reflection of the capacity of public health. When this exploded, they were doing a few tests a day, and that turned into thousands of tests a day. Apparently, when I was listening to the news this morning, there is a plan from the government of Ontario. So this is one of these things that will change probably throughout the day to help with that bottleneck and notifications. But yeah, that's, again, more of a systems process, I think, than a clinical process.
Okay, and this there's a big question about PPE. So especially since there are reported shortages in different places, recent deaths of frontline healthcare workers in kind of New York State and New Jersey, and the idea that the World Health Organization standards in China and Korea were pretty much, I think, droplet, although they seem to take it further with kind of full body gear in some of the COVID only institutions, I think. And then the CDC recently has endorsed kind of like, if you're out of PPE, maybe a handkerchief or a scarf might be used, but they can't guarantee that. What's your stance right now? I know there's a lot of volunteers, a lot of people really coming out of the woodwork to really find us PPE, so that's great. I think our story is a little bit different from the American story right now, but
I think the number one, we have reasonable evidence and reasonable data from prior that in SARS, that droplet transmission was the major route. Mark Loeb, who's our division director, had done a case-controlled studies of critical care nurses during SARS that looked at people who wore N95 masks versus droplet masks. And in fact, the people who wore N95 masks, the nurses that wore N95 masks had a higher risk of SARS than people who wore droplet masks. Mark also did a study on influenza, looking at N95 masks versus droplet masks. And subgroup analysis was looking at human coronaviruses too as well. And again, the human coronaviruses, the typical ones that circulate that aren't as pathogenic, were entirely the same between the groups that got N95 versus droplet. It was some small numbers, I think about 10 or 8 in each group, but at least some data there suggesting that the droplet mask is reasonable and fits with World Health Organization, Public Health Agency of Canada, Public Health Ontario recommendations and droplet precautions outside of aerosol generating procedures. The other question about the cloth mask is interesting. I've been asked a lot about this recently. There is a paper from BMJ that looked at homemade cloth masks in the prevention of influenza-like illnesses from 2016. And essentially the particulate filtering was pretty much like, it only filtered 3% of the particles, so 97% of what went through. And the rates of influenza-like illness as compared to regular masks were much higher in the group that was wearing cloth masks, There was also some concerns about the humidity introduced in cloth masks. So you can imagine wearing a handkerchief on your face all day, you're going to get a very humid face from just, from the vapors in your mouth. And so that might actually increase your acquisition. So I think cloth masks are a last resort on the CDC list of interventions for PPE prevention. That's on the last leg of the list, other than things like reusing masks and that type of thing. Mm-hmm. And so I don't think cloth masks are effective. And the World Health Organization actually just on their guidelines say don't use it in any clinical setting. So I think they actually may introduce harm, not benefit.
Yeah. And so just going back to your kind of comment about the ankle x-ray probably not being good for an NPS in this case.
Yeah.
Let's say someone has a fracture though, and has, maybe some kind of like, especially allergy season, some confusing symptoms. Do we swab that person before sending them to the OR?
Yeah. And we're actually developing policies around this. So because we have access to good testing in-house, we have talked about using swabs prior to aerosol generating procedures, whether or not they're elective or non-elective. So intubations, even for asymptomatic patients. And I think this is more for the sake of preserving our PPE supply so that people can continue to wear droplet masks if they swab negative. There's obviously concern with asymptomatic shedding, that if you are, someone's asymptomatic, they break their ankle, they have to go to the OR, they're asymptomatic shedding COVID, and you intubate them with an NA5, you might spread it around the room. So in that particular context, right prior to an aerosol generating procedure, we are looking and will likely institute a policy around that to keep down PPE. But obviously these are decisions that are made with lab supply and demand in mind too as well.
Yeah, so that would be...
this is something that will be coming down the pipeline. Let's just say that.
Okay. And then can you explain the rationale a little bit behind the St. Joe's announcement that patients admitted or being admitted for 7 days will be tested?
Yeah. And I think that was another look at, again, just patient safety standpoint. Remember, our visitor policy came into effect about a week ago. And so those patients that were there greater than 7 days had exposure to visitors. And so we know that the incubation period is between 2 to 10 days. And so it's really just to start with a fresh slate and say those patients that had a lot of community exposure that are still sitting in hospital are tested, just to know their status. And then everyone else going forward is again, a clinical discussion more than anything else.
So it's more like an epidemiologic control.
Yeah, exactly. And just again, fresh slate, right? Like the people that were exposed to visitors that we don't know their status, that we know the patient's status that are in hospital. God forbid they need an aerosol generating procedure.
All right. One more question from Tim Crutchy, who is asking if you can comment on reinfection.
Yeah, this is evolving. Remember, this is 4 months old, right? So we have cohorts now that are only 4 months old that have been infected in November. There is some data about people that had virus detected 6-8 weeks later. It's very unclear whether or not those patients were just prolonged shedders with low-level viruses versus patients who actually reacquired the infection or reacquired and are just asymptomatically shedding the infection. We know, for example, dogs can asymptomatically, we can find it in their nose. They don't get sick with it. They might shed it a little bit. We don't really know what the World Health Organization says. They're not a big issue. So the bottom line is this is probably data that will come out down the line in terms of the reinfection rate. The promising thing is the Wuhan population seems to be very stable. And so if there was a trend towards reinfection, or immunity not being long lasting, that population would likely break down if they kept circulating within the population. So there may be some defined immunity just by looking at populations that have dealt with it and have stopped dealing with it, basically.
Okay, yeah, we'll take a look because I think China's letting loose some of their protocols now. So we'll see. I'm sure they'd be the first to report because they're first to kind of control. All right. Well, thank you very much. There's a lot of really great questions here. I'm going to copy a copy of the group chat, and maybe I can send you some of the extra questions over. We can put them in the YouTube channel comments.
Perfect.
or in the show notes for the YouTube. Zain, I might be in touch to ask you a couple of follow-up questions or something like that.
Sure.
So maybe you can send me a voice memo for some things. But other than that, thanks everyone for tuning in today. Thank you so much, Zain, for your time.
Yeah, not
You
a problem.
are definitely a leading expert in our area, mainly because you've been living the life of 24 COVID right now. There's a lot of people here that are very grateful for your time. Thumbs up from everyone. And I think that one of the quotes that really stuck out to me was that we swim together or we sink together. So I think that like that's something to remember when communicating with our patients and our colleagues. That we're all in this together as humans, as a community. So hopefully we can all kind of like stay up on all of these protocols and changing things. So thank you so much for keeping us up to date. And I think Dr. Crowther is still on a line, I think, is he? I can't see if he wants to say anything. Mark?
No, just thanks, Zain, for a truly outstanding set of rounds. It was amazing that you pulled all that evidence together on short notice. And thanks to the attendees, we maxed out at just under 300. We had 283 at peak, so that's insane. For those who've asked, if you can just tell others, as Dr. Chan just said, we will be putting this up on YouTube later on today. Dr. Merckx's rounds from 2 weeks ago has had an insane number of views, and I anticipate this will get an insane number of views as well. So thanks, everybody, and thanks, Zain, for doing this. We'll chat with you later.
Thanks. Zain, I might give you a call in a couple of seconds, just a couple of follow-up things, but I'm going to stop the recording now.